Welcome, everyone. I'm Michelle Cowles, Vice President of Business Development and Admissions with Rogers Behavioral Health, and I am your moderator for today's webinar, Sleep Awareness and Mental Health. Joining me today is Dr. Christopher Louden, Associate Medical Director of Rogers Central Service Area. And we had formally planned for Dr. Adrienne McCullers, Senior Clinical Director of our Eastern Service Area, to join as well. But rather today, she is welcoming her baby into the world. So Dr. Louden has graciously agreed to go solo. So we will make those adjustments accordingly. Before we get started, I just want to give our participants a quick overview of the format. The webinar is scheduled for 90 minutes, and to receive your CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available immediately after the program via email, with a link to your personal dashboard on ce-go.com. In addition, a recording of the webinar will be published on the resources section of our website within the next day or two for you to rewatch. Our speakers will give a 70 to 75-minute presentation, and following the presentation, I will facilitate the Q&A session. So during the presentation, please refrain from using the chat feature as it's a distraction to the presenters and other participants. If you would like to ask our speakers a question during the presentation, please use that Q&A button, not the chat button, to send me a message. And at the bottom of your screen, you just simply click on the Q&A button on your Zoom taskbar. I will review the questions submitted, and then the presenters will address them during the Q&A portion of our webinar. Now I'll turn it over to our presenter, Dr. Christopher Louden.
Thank you very much, Michelle. Hello, everybody. I'm happy to be with you here today, and good afternoon, good morning to those of us on the west side of the country. I have no real disclosures to give. Learning objectives for today. I will be going over the 4 stages of sleep and at least 2 functions of sleep. There actually be more than that. We'll talk about sleep hygiene and at least 5 different techniques that one can use to help improve sleep. And then I'll also be talking about pharmacotherapy and Cbti as it relates to sleep and insomnia. So what we'll cover is first off an overview of sleep, some sleep architecture in terms of neurophysiology of what's going on in the brain, neurobiology, functions of sleep, recommendations for sleep overall. So we'll go over common sleep problems, different types of sleep problems, diversity of sleep problems amongst the general population, and consequences of sleep deficits. And then we'll also be targeting sleep-related difficulties. We'll go over sleep hygiene. We'll go over cognitive behavioral interventions for sleep difficulties, covering pharmacotherapy. I'll give a brief overview of chronotherapy for mood and sleep disorders, and then we'll have Q&A. So sleep. One disclosure I'll make is that I did a lot of preparing for this webinar. I've also done, I guess, some observational research, having a new 6-week-old at home. And so sleep is something that is not coming easily at our household right now. So I've been able to observe myself in periods of sleep deprivation. I've also been able to observe my daughter as she drifts in and out of sleep throughout the day. So I'm bringing some of this real-time information to you to the webinar. So the mystery of sleep. It begs the question, why do we sleep? Because it's a period of time that goes counter to what you would think of, that goes counter to evolution. I mean, it's a period of time where we're unconscious, we're not responsive, we don't eat, we don't reproduce, we can't monitor for safety, and we spend 1/3 of our lives doing it. So I mean, you'd have to think that the survival gains from sleeping outweigh the risks of sleeping, but we're not really sure how that balance works out in everyday life. We have some hypotheses, which I'll go over. And so there are big costs if we don't sleep. If we don't sleep, we can deteriorate cognitively. If we only get 4 hours of sleep, we have the cognitive abilities of someone who is legally drunk. And just a sleep deficit of 2 hours correlates and corresponds to a blood alcohol level of 0.045. Full disclosure, I got my 8 hours last night, so your presenter is healthy and awake for today. So let's go over the sleep stages. EEG was really one of our first ways to start looking at what's happening in the brain during sleep. Up until then, it was really just, observational. We see somebody that's unconscious and, they hallucinate in the form of dreams and really don't have much insight into what's going on. And so EEG allowed us some of that glimpse at the different stages of sleep. The other ways that we can monitor people during sleep are electroocculogram, which measures eye movements, electromyogram, which can measure muscle movements. So that helps add some additional information as well. So when we're awake, this is what our brainwave activity looks like. Eyes are open, low voltage, meaning low amplitude, fast activity happening. When our eyes close, that brainwave changes and we see what's called alpha activity. That's our idling rhythm. Still low voltage and still fast activity. At that point, both our eyes and muscles are moving voluntarily. So stage 1 is our transition state. This is when we lose the alpha activity of the wake state and we start seeing different sort of waves in the EEG. These are theta waves. During this time, we could see some slow eye movements, rolling, muscles start to relax. This is when I'll see my daughter's eyes go up into the back of her head as she's drifting off to sleep. And at that point, the subject may not even know they're sleeping. I've had instances where I'm falling asleep on the couch and my wife will say, "Wake up." And I'll just say, "Well, I wasn't sleeping. I don't know what happened." That's what happens in stage 1 sleep. Stage 2 sleep can happen after just a few minutes of being in stage 1. The brain waves change again and we start seeing K complexes and sleep spindles. At this point, we're considered sort of fully asleep and our arousal threshold is increased, meaning the stimuli that it takes in order to wake us gets stronger and stronger and needs to be stronger and stronger in order for us to wake up. Stages 3 and 4, this is what's called slow wave sleep. You can see here in the EEG, you'll notice slow waves. The amplitude is higher and the waves are coming much less frequently than we see in a wakefulness state and we see in stages 1 and 2. At this point, our eye movements stop. Muscle tone, muscle movements continue to decrease and the threshold for arousal becomes higher and higher. It becomes a process to wake up, which I'm sure we're all familiar with. And then we get into REM sleep, rapid eye movement sleep. In this stage, we see a burst of eye movement. It's interesting to see this in a person and an infant for the first time. Their eyes just start darting around and moving and almost like they're vibrating. The EEG, oddly enough, is similar to when we're awake. You see again that low amplitude, that higher frequency brainwave, and what's called sawtooth waves. At this stage of sleep, we have a loss of muscle tone, and the arousal threshold is still very high during this period. And so what does that look like throughout the course of the night? We spend very little time in stage 1. A lot of time in stage 2, and then the rest of the time in stage 3, 4, and REM sleep. As we fall asleep, we fall down the stages of sleep to stage 1, 2, 3, then 4. And then we go back up, eventually ending in REM sleep, just to repeat the cycle over and over again. You'll notice as the night can go on, we're spending less time in stages 3 and 4 and more time in stages 2 and REM sleep. This is helpful. If we're not sleep deprived, we'll see this. It's more helpful because in the morning comes, we want to be able to have a lower threshold for arousal to be able to wake up in the morning. So I'll move on to what's happening in the brain and the neurophysiology and the hormones and chemicals that are responsible for wakefulness and sleeping. Arousal in general is regulated by a loop called the corticostriatal thalamic cortical loop. That's pretty much just the waypoints, the anatomical waypoints along the way for this loop. And these control the thalamic filter. Now, the thalamus is a part of the brain which it does a lot of things. One thing that it does is it filters lots of information from one part of the brain to the other. It filters sensory information, it filters motor information. And so parts of this loop can kind of adjust the information that's getting through and how the brain deals with it. In our hypothalamus, that's where our sleep-wake switch is located. Our main wake promoter is in the tuberomammillary nucleus. Our main sleep promoter is in the ventrolateral preoptic nucleus. The lateral hypothalamus is the part of the brain that promotes wakefulness, often speaking with the tuberomammillary nucleus, not speaking literally, but communicating physiologically. And the suprachiasmatic nucleus is sort of our internal clock. It's like our sleep pacemaker, keeping the circadian rhythm going as we go throughout our day and days. So the first hormone that I will touch on is the hormone Erection. And this is a wakefulness promoter coming out of the lateral hypothalamus. It is secreted during times of wakefulness to help keep us awake, and slowly goes down over the course of the day as our sleepiness builds. This hormone is lacking in narcolepsy, which is why we see much difficulty with people staying awake in that disorder. And so here you have the orexin acting on this sleep seesaw to push down on the wakefulness side. I like to think of each of these sort of hormones or sort of levers being pulled to tilt the balance between sleep and wakefulness. And so orexin is, you can imagine the child on the wakeful side of the seesaw, pushing that part of it down. Pushing us towards sleep on the opposite side of the seesaw is melatonin. That's a hormone that programs the suprachiasmatic nucleus. Remember, that's the part of the brain that is sort of our clock and controlling our circadian rhythm. Melatonin is secreted by the pineal gland in response to darkness. Darkness of light around us can promote sleep, but there's also other external triggers that we might see as well. And melatonin we see increased amounts throughout the day, as well as through the night. Histamine is another wake promoter, secreted by the tuberomammillary nucleus. It promotes wakefulness and is pro-cognitive. And what we see is that when we use antihistamines, medications that block histamine receptors like diphenhydramine, you can get the side effect of sleepiness. You'll see that in a lot of medications that end up, whether intentionally or not intentionally, blocking histamine. And so you can get a main effect or a side effect of sleepiness. And then there is Gaba. which is our major inhibitory neurotransmitter. If GABA gets involved in neuronal firing, it increases the threshold at which that neuron can fire. So it essentially inhibits that neuron from firing. In that way, it can globally act as a depressant in the brain. And so it promotes sleep, inhibits wakefulness. If you sort of work at GABA receptors too hard, you can get further and further depression in the brain, which we can talk about more when we get to medications that may affect GABA receptors. And then adenosine. Adenosine is a neurotransmitter that exists all by itself. And it is, you can think of it as sort of one of the things that's like a garbage buildup while we're awake. It accumulates while we're awake, and only sleep can dissipate the adenosine. What we can do, and one thing that we use often to help stay awake, is caffeine, which blocks the effects of adenosine. And I should say it emphasized blocks because it doesn't get rid of adenosine. There will become a critical point where caffeine can't block the adenosine that's out there, and adenosine wins. Or the adenosine buildup is so high that when that caffeine exits our system, we get a big crash. And so that's where we can get in trouble with using caffeine, which is also, we can develop a tolerance to when trying to stay awake. And so what the picture I'm trying to paint with these different parts of the brain and the different hormones, different chemicals, different neurotransmitters, is that throughout the day, they act to sort of build up the machinery for sleep. We accumulate some of these hormones, we accumulate stimuli that drive us towards sleep until we get to a critical point later in the day where we fall asleep. Sort of like the tide coming in from the ocean. The further the water comes in, the more sleepier we're getting until we fall asleep, and then the tide can go out again. And so these hormones are able to reset while we're sleeping, only to start again the next day. And so this sort of wave pattern is what you see when we're talking about the circadian rhythm. And the higher that sleep pressure goes, the more likely it is that we'll fall asleep. And so circadian rhythm, that is an example, that wave pattern sort of indicates our circadian rhythm. Our circadian rhythm can be influenced by a lot of things. The things that influence the circadian rhythm are called Zeitgebers, which is a fun word to say. It literally means time givers. These are stimuli such as light, dark, other environmental factors that I can go into later. We can have circadian rhythm disorders. So when the phase of our circadian rhythm is delayed, we have an issue where the wake promoter is turned on too late in the 24-hour cycle. In these patients, or in these folks, we see people that are night owls, people that are up way late at night. They may fall asleep not till 2, 3 in the morning, and then they're sleeping in until later in the day. This is what we see in phase delay. And naturally, adolescents, teenagers are more phase delayed than adults or children. And so that's where we get, I think, sort of the stereotype that teenagers are constantly sleeping in, they're up late at night. Phase advanced is when the wake promoter is turned off too late in the 24-hour cycle. And what we see is folks that are going to bed very early, and then maybe up very early in the morning. And so both of these patterns can cause issues when they come up against real life situations, work, school, anything that requires a schedule. The good news is when treating these issues or when affecting the circadian rhythm, we can artificially influence them to try and move things around a little bit and shift the phases back where they need to be. So functions of sleep. I alluded to the I alluded to the point that we don't really know everything that's going on during sleep. We have some hypotheses. And so those are some of the hypotheses. These are some of the hypotheses that I'll review today. So it's long been thought that sleep can consolidate memory and enhances learning. You know, the old wives' tale of, you know, you sleep with the book under your bed and then you'll retain the information. And so the exact mechanisms here are unclear, and it's not really known if REM sleep is the stage of sleep that has anything to do with this. But there is some evidence to support that good sleep can enhance memory of what had happened previously or what one was looking at, maybe studying before going to bed. Sleep and brain restitution. Our brain is using fuel all day long. It never stops thinking, it never stops going. And it's thought that this fuel that is in certain parts of the brain can be depleted, and that byproducts of this can build up, sort of like the garbage of the day can kind of build up through the brain. And so that sleep is needed to kind of restore the fuel, to kind of clean up, clean house, so that the brain can go back to functioning at its normal level the next day. You know, and this, something is happening as we're awake, because if we go past the point where we're sleep deprived, we do see that rapid cognitive impairment that I spoke about earlier. And then sleep and synaptic homeostasis. So in this hypothesis, it's thought that wakefulness is associated with synaptic potentiation, meaning those synapses just kind of getting stronger. I kind of think of this as like a traffic jam. There's so much information going through the synapses all day that it gets heavier and heavier. It requires more effort to push it through. Stuff builds up. And so we need that break for the brain to kind of reset. So these synapses that have been sort of essentially getting stronger and stronger and overused throughout the day can go back to their normal baseline, so that the brain can function again normally. And that process at night where the synapse goes back to normal is called downscaling. And it's thought that that occurs during slow wave sleep. Another function of sleep, brain development. Obviously very important for my daughter right now. Her brain is growing and learning every single day, as is most of our brains growing and learning all throughout our lives. Most of brain development is happening before the age of 30. And one specific piece of you know, perhaps correlational evidence that REM sleep is responsible for brain development is that as we get older, the amount of REM sleep that we're getting tapers off. And so how much sleep? Newborns. My newborn probably does sleep 14 to 17 hours a day. I can guarantee you that none of that is consecutive. So that would sure be nice. As we get older, our sleep consolidates to certain parts of the day. And then as an adult, 7 or more hours per night. And this is from the Centers for Disease Control and Prevention. So now I will review common sleep problems. So sleep disorders, common characteristics. Over the course of the lifetime, sleep problems are reported by up to 1/3 of adults. It's very common. 25% of children and adolescents or young people are not necessarily sleeping as well. Most sleep disorders can be excuse me, characterized by one or more of the following: trouble falling or remaining asleep, insomnia, finding it difficult to stay awake during the day, hypersomnia, imbalances in circadian rhythm that interfere with healthy sleep schedule. I talked about that a little bit with phase shifts that we can see in the circadian rhythm. And sometimes we'll see unusual behaviors or odd phenomenon that can disrupt one's sleep. So types of sleep disorders that I'm going to review right now. We have insomnia, parasomnias, breathing disorders, hypersomnolence, sleep-wake disorders, and sleep-related movement disorders. We'll go through each of those one by one. So insomnia. 10 to 30% of adults live with some form of insomnia. That's a lot. We've probably all, most of us have experienced it at some point in our life. It's a persistent difficulty falling or remaining asleep, despite the opportunity and the motivation to do so. Everything's primed and ready to go for sleep, it's just not happening. Chronic insomnia is defined as at least 3 times a week for 3 months. Short-term insomnia is lasting less than 3 months. Parasomnias. Unusual behaviors that occur prior to sleep, while asleep, or during the transition between sleep and waking. One common parasomnia is that sensation of falling, or that jolt that we'll get as we're falling asleep, is pretty common and not necessarily very impairing in most. And so non-REM related, we can get sleepwalks, night terrors. REM related, we can get sleep paralysis, which can be very anxiety provoking for the people that experience it. Sleep related breathing disorders, essentially abnormal breathing during sleep. These can be highly disruptive. These can cause a lot of problems, and problems like obstructive sleep apnea, I think, can be underemphasized in terms of how they contribute to our overall sense of wellness and health, and can lead to some major daytime impairments. Obstructive sleep apnea is when there's a physical obstruction that prevents the exhalation and inhalation. Central sleep apnea is when there's a part of the brain that is affecting our ability to breathe effectively. Hypersomnolence disorders, feelings of sleepiness and fatigue during the day, despite a healthy circadian rhythm and enough sleep. Narcolepsy is one of the more common examples of this, when we lack the orexin that I was speaking about earlier. That is the most common hypersomnolence disorder, and can put people at pretty high risk for negative outcomes and accidents when experiencing it. Sleep-wake disorders. This is what I was talking about earlier with circadian rhythm sleep disorders tied to a person's internal clock. When the circadian rhythms are misaligned, we can see things get out of whack, and it makes it difficult for people to sleep when they want to, be awake when they want to, or feel sleepy when they'd rather be awake, or feel awake when they'd rather be sleepy. Sleep-related movement disorders, these are abnormal movements during sleep. They can be disruptive. They can get to the point where they're maybe not even disruptive to the patient, but disruptive to the patient's partner or person they share a bed with, waking them up frequently. This can cause excessive daytime sleepiness for both, and fatigue due to sleep loss. Restless leg syndrome is an example of this type of disorder. Diversity among sleep disorders. Women are at 40% increased risk for insomnia and developing sleep problems compared to men, which is at 22%. Women are at twice the risk for restless leg syndrome compared with men, and men are at twice the risk for sleep apnea than women. And narcolepsy is also more male predominant. In terms of ethnicity, Black or African American individuals are at a higher increased risk for insomnia. More early morning awakenings plus lower sleep efficiency in African Americans versus white adults. There is a shorter duration and higher rates of sleep apnea in African American, Hispanic, and Asian children and adults as compared to white children and adults. Earlier start of puberty in African American girls and then in Hispanic, Asian, and white girls, which predicted shorter sleep duration. Socioeconomic status also affects sleep. Compared to those individuals in more advantageous conditions, individuals who experience economic difficulties and the stressors along with that, lower educational level, and those with lower socioeconomic status are more likely to experience sleeping problems, as well as a myriad of other mental health issues. For women, childhood and current socioeconomic status issues is significantly related to sleeping problems later in life. For men, current issues with socioeconomic status is significantly related to sleeping problems. And one thing to highlight is that there is a huge interplay with sleep deficits and the impact on mental health. many of our mental health problems are associated with sleep problems. We see this all the time. I see this all the time in practice. Symptoms of insomnia are present in 20 to 40% of individuals with mental illness, according to this statistic, which is actually surprising to me. I don't think it would be actually higher. We see this in major depressive disorder. One of the diagnostic criteria is changes in sleep. Bipolar disorder and mania and hypomania, we see sleep problems. And then on the opposite end, in the depressed part of bipolar disorder, we see sleep problems. Generalized anxiety disorder, and one of the criteria again is disrupted sleep. In PTSD, the hypervigilance can lead to significant sleep problems, as can night terrors and nightmares. In schizophrenia, we see that it takes longer for patients with schizophrenia to get to sleep. They end up sleeping less, and this can impact them cognitively and compound the negative cognitive effects of schizophrenia as well. And alcoholism can greatly affect sleep as well. A little bit more on that part later. People with insomnia and hypersomnia are 10 times more likely to develop major depressive disorder. 75% of those with depression report symptoms of insomnia. So there you see that back and forth. Sleep issues causing depression, depression causing sleep issues. Patients with insomnia without depression have an odds ratio of 6.2 times more likely to develop depression later in life. Patients with depression without insomnia, the odds ratio is 6.7 times more likely to develop insomnia later in life. Patients with insomnia and mood disorders, 41% of patients with insomnia and mood disorders, the insomnia preceded the mood disorder. 29% the mood disorder preceded the insomnia. And so it's not really a chicken or the egg type question. It's both. It could be either or. Sleep deficits and mental health impact. This was a study done a large number of people. Those with comorbid mood and anxiety disorders had significantly higher rates of severe insomnia complaints as compared to other groups. Severe insomnia complaints were also more prevalent in individuals with mood or anxiety disorders relative to those with no disorder. And severe insomnia complaints in the past year was associated with increased days of impairment for those with mood and anxiety comorbidity. Insomnia is the most common sleep disturbance associated with anxiety disorders. Much like in depression, those with insomnia are at much higher risk, double the risk for developing anxiety disorder. People who have an anxiety disorder, 70 to 90% of those experience some form of insomnia. And as I was talking about in PTSD, 90% of individuals diagnosed with PTSD report symptoms of insomnia, which makes sense, being that the brain is sort of in a hyper-aware, hyper-adrenergic state a lot of the time. Sleep deficits and mental health impact. Sleep disturbances can increase risk for suicidal behaviors. One of the top 10 warning signs of possible suicidality and that's from SAMHSA. Insomnia and nightmare symptoms may serve as a modifiable risk factors for suicidal behaviors. We can talk a little bit more about that later. And the relationship between suicidality and sleep disturbance has been shown even in the absence of mental health. So even without a diagnosis, lack of sleep can increase the risk of suicidality. Now, targeting sleep-related difficulties. Why treating sleep is important. If we haven't driven home this point yet, we're going to continue to do so. A disturbed sleep pattern predicts poor response to psychotherapy. So your patients with poor sleep patterns are going to respond less favorably to psychotherapy. Insomnia is a risk factor for relapse in patients who are treated for depression. And treating insomnia in terms of psychotherapy treatments, treating insomnia with Cbti in patients with depression does result in decrease of depression scores, decreased relapse, and improved remission rates. So I mean, the take home of a lot of this is screening patients, screening our clients for sleep issues. It's one thing, it's one of my vital signs as I'm talking to patients. How are you doing with sleep? How is sleep? Are we doing everything we can to address your sleep? Medications, behavior changes. We'll go through some of these. Cognitive and behavioral interventions first. We'll go over sleep hygiene, cognitive restructuring, what that looks like, and the components of cognitive behavioral therapy, insomnia, sleep restriction, and stimulus control. So the 3P model for insomnia. Predisposing factors, the traits. Precipitating factors, the states. And perpetuating factors, the behaviors. We'll go through each of these, but predisposing, meaning genetics, the wiring, our internal biology. Precipitating factors are how stressful events can affect our ability to sleep and can then affect our biology, and to a certain extent, even genetics. And then there's perpetuating factors, behaviors that cause insomnia to persist. So predisposing factors, traits, genetic vulnerabilities, personality traits, type A personality, anxious, those who are in a state of hyperarousal tend to struggle more so with insomnia. As we talked about before, medical and psychiatric problems, such as anxiety disorders and depression, are closely related to sleep issues. The risk factors that we spoke about earlier, gender being female is a predisposing factor for insomnia. Age being older also can lead to, also correlated with more instances of insomnia. Precipitating factors, acute stress life events, psychosocial stressors, acute safety concerns, and that sort of also gets at, problems that we may face in patients with socioeconomic struggles, or acute safety concerns, not just from their surroundings, but also being able to support oneself emotionally, nutritionally, health-wise. Onset of worsening or medical psychiatric conditions can affect sleep as well. Perpetuating factors, behaviors. So these are things that one does to try to get more sleep at night. And they can affect sleep in ways that we may not necessarily think about, or certainly the patient or the client may not necessarily think about. Going to bed early, sleeping in, drinking alcohol, all affect sleep. Things you do the next day make up for limited sleep. So they may avoid exercise, reduce activity, take a nap, drinking caffeine. These are all sort of like compensatory things that we may involve ourselves in, that can then go on to affect sleep. And then anything you do in bed that is not sleeping can affect that association that your brain has of bed with sleep. So reading, electronics, TV, talking with partner, worrying, feeling frustrated, problem solving. And perpetuating factors can change. The goal is to look like this little sleeping child who appears to be so happy and content. The correlation that we want to happen is I'm in bed and I'm asleep. And that can unfortunately sometimes turn into I'm in bed and I'm doing this instead of that. So I'm in bed and I'm looking at my phone. I'm watching TV. I'm reading, or there's a bright light close by. Also, I'm in bed and I'm feeling the feelings of hopelessness, frustration, anger, depression, anxiety, all preventing my brain from being able to get to sleep. So I'm in bed and I'm asleep then turns into I'm in bed and I'm awake. So we get this conditioned arousal that can happen in insomnia. Instead of the bed becoming associated with sleep, the bed becomes associated with anxiety. I look at my bed and I'm thinking, I'm just not going to get to sleep. It's never going to happen. last night I didn't get any sleep. I just laid awake anxious for hours. And so you're anticipating that the next night. So you even see your bed, and without the thoughts even occurring, you're starting to get those feelings of frustration, anxiety, hopelessness. You're starting to get hyperarousal, which is exactly what we do not need when we're trying to get to sleep. So Cbti really tries to get at the associations that people have with sleep and the thoughts that they have around sleep. It is recommended as practice standard and first-line treatment for insomnia. It is found to be as effective as medication for brief treatment and more reliable over the long term than medication. However, there are roles for medications as well. The key components to Cbti are sleep hygiene, cognitive restructuring, stimulus control, and sleep restriction. I should note, though, sleep restriction can sometimes be helpful in resetting the body clock and helping get people back to sleep on a regular basis, but it's contraindicated in some disorders like bipolar disorder. Don't want to tip somebody over into hypomania. Untreated sleep apnea, parasomnias can get worse if someone is sleep deprived and goes to sleep. Seizure disorder, sleep deprivation can increase the risk for seizure disorders. And so the type of treatment should be monitored or should be modified in those cases, excuse me. It's very effective. 70 to 80% of patients with even long-term very poor sleep benefit from Cbti. It's been studied a lot, more than 100 randomized clinical trials over 30 years. Very good long-term outcomes to 80%. And 85% of long-term nightly prescription users were able to eliminate the prescription altogether using Cbti combined with gradual tapering protocols. Prescription meaning medications geared towards treating insomnia or geared towards treating insomnia. Sleep hygiene. What is sleep hygiene? Just like tooth hygiene, it's something that we should encourage our patients or clients to do every day. It's healthy sleeping habits that can help improve the ability to fall asleep, stay asleep. It's an important part of CBT. It's a huge part of the psychoeducation part of CBT. A lot of people don't know that their compensatory behaviors for not sleeping are not helping them, or some of the behaviors that they now associate with bed are also not helping them. It's very effective for treatment with chronic insomnia. This kind of goes over again what I had mentioned before. How much sleep do I need? Infants, again, 12 to 16 hours, not consecutive. And then that decreasing and becoming more consolidated up through childhood, teenagers, and then less as adults. And this time is from the American Academy of Sleep Medicine. Sleep hygiene tips. Get regular. Have a routine, making sure that your sleep patterns are consistent day to day. This may be difficult for people who have work obligations or work hours that are not conducive to having regular sleep. When you're sleepy at night, sleep. If you're not sleepy, try and get up and try again. Again, we're trying to avoid that association that can happen of wakefulness and sleep. We're trying to avoid the never-ending hours, minutes staring up at the ceiling. So get up so you don't associate your bed with being awake. We want to avoid caffeine and nicotine, which are stimulants, before sleep. Avoiding alcohol is actually a common misconception that I run into amongst my patients, specifically those who are anxious, is wanting to have a drink before bed, feeling like that helps them sleep. And it may help them fall asleep, but it's certainly not doing them any favors after that. Alcohol is quickly metabolized by the body. And then what happens in the brain is once that depressant is gone, that the brain has been pushing back against with excitatory neuronal responses, excitatory neurotransmitters, those excitatory neurotransmitters and impulses still exist as the alcohol is leaving. So then you get a hyperarousal state while you're trying to sleep. And that prevents you from sometimes just sleeping, and you may wake up. And that also prevents people from getting into deeper stages of sleep that they might need to be getting in. Again, we want to make that association of bed is for sleeping, and in making sure that our circadian rhythm is regular, not napping during the day. I always tell my patients that sleep is like pizza dough. If you want it to be nice, solid, consistent piece of dough, if you start spreading it out throughout the day at different times of day, you develop all these holes. And what you get is a not very good looking or not very appetizing pizza, or a difficulty with your circadian rhythm. Bath time, some people find that that bathing, the warm temperature and relaxation that comes with it can be helpful before sleep. You don't want to watch the clock. That can lead to more anticipatory anxiety. The thought that comes to mind is, well, if I fall asleep now, I'll get 6 hours of sleep. Well, if I fall asleep now, then I'll get 4 hours of sleep. And just thinking like, eventually the clock wears out on that, and you've just been thinking about how much sleep you're going to get without trying to relax. Using a sleep diary can be really helpful in understanding our sleep patterns and learning new associations. Exercise can also help promote wakefulness during the day. Also just makes us more healthy and primes our body for sleeping at night. Eating right, having a good diet, having the right space to sleep is important, and keeping your daytime routine the same. Any sort of 24-hour cycle of routines is going to be helpful for our 24-hour circadian rhythm. Cognitive restructuring, and this is the sort of the cognitive part of the CBTI. So negative sleep thoughts. I'll never be able to sleep without pills. I see that very often. This is going to be another terrible night, is a negative thought that people can have. Wanting to try and push those thoughts or restructure them more towards, I'll be sleeping better if I learn these new techniques, or these techniques have worked for others and they will work for me. Just like in regular CBT, doing thought charts, tracking these negative sleep thoughts, challenging them, replacing them with positive sleep thoughts is an important part of CBTI. Stimulus control. And so this intends to reestablish the association between being in bed and being asleep. So bed equals sleep and relaxation, as I spoke of before. It asks patients to get out of bed and engage in a relaxing activity outside of the bedroom anytime they're not asleep for 15-20 minutes or are clearly awake. Again, emphasizing not wanting to associate wakefulness with the bed. And patients are then told to only return to bed when they're so sleepy that they can hardly keep their eyes open or nodding off, just so they can the idea is just kind of float right into bed. Patients are told to only engage in sleeping and sexual activity in the bedroom, so that sleep is first and foremost association with the bed. So we want people to spend less time in bed awake, weakening the conditioned association between being in bed and being awake. Again, weakening the conditioned association between being in bed and experiencing physiological arousal. So the less time that the patient or the client spends in bed awake, the less time they spend in a state of hyperarousal in bed, the less that their brain will start to associate those things with bed. And this leads to people spending more time in bed asleep, and is the goal. Even if it's not happening consistently enough, just the sleep is happening in the bed. Even if that's not coming very easily, it's still happening in the bed to rebuild that association between being in bed and being asleep. Sleep restriction can be calculated based on one's sleep log completion. Working to spend less time in bed until we get to better sleep efficiency. And so the idea is building up a sleep debt so that makes one more tired, more likely to fall asleep and sleep deeper, become more efficient in sleep, have less wakefulness during sleep. Going through sort of cycles of this, never restricting more than 6 hours. And going back to the diary, if sleep efficiency is still less than 80%, patients need further sleep restriction. So in a case study, Michaela is a 26-year-old female competitive skier. She has no known psychiatric history, however, has developed insomnia each night before a race. Immediately upon going to bed, she becomes anxious and begins to think about getting enough sleep so that she can perform her best on race day. This problem has led to some recent problems with focus during the day, which has led to underperformance in her competitions. She is seeking help to get better, more consistent sleep. And so the question is, what are some treatment considerations as you approach Michaela's case? Well, we've already gone through a good deal of them. Michaela is a female, putting her at higher risk for insomnia. Right now, she has got no known history, psychiatric history that would contribute to the insomnia. But again, you don't have to have a psychiatric history in order to develop insomnia. What seems to be happening here with Michaela is she's, because of the cost to her of not sleeping, leading to decreased focus and poor performance the next day, she started to become very anxious about not getting enough sleep. And so she thinks now that that association has been made, she's thinking about sleep. This makes her anxious about getting to sleep, which puts her in a state of hyperarousal, making it less likely to get to sleep. This is where CBTI can be helpful in sort of trying to dial back those negative associations with sleep. And so trying to have Michaela spend more time in bed sleeping, relaxed, less time in bed thinking about how she's going to do the next day in her performance, her race performance, or the other things that can affect her. All using the tools that I described just earlier. Other things that can be considered in Michaela's case that we can talk about coming up next, that I'm going to go into, is different types of therapies outside of psychotherapy that we can use to affect sleep. So pharmacotherapy, medications for insomnia. Hypnotics are the class of medications that treat insomnia, make people sleepy. Insomnia can occur intermittently or become chronic, as we spoke about before. Psychiatric disorders commonly cause sleep problems. And untreated insomnia can increase risk of symptom relapse. All these are reviewed from previous slides talking about the interplay between mental illness and sleep and mental health and sleep. The complication that you can run into with medications is you want to get the length of an effect just right. You want the Goldilocks medication. If it doesn't help promote sleep enough, then insomnia can persist. If it promotes sleep too much, then you can have too much sleep going in the next day and a hangover effect, ongoing effects of medications going into the next day. Benzodiazepines is one class of medications that is used very, very, very frequently in trying to treat insomnia, and some may argue too frequently. The medications listed there are the medications that are approved in the United States for treatment of insomnia. There are definitely some drawbacks to using benzodiazepines. You get a loss of efficacy over time due to tolerance. The brain builds up, the receptors build up tolerance to these medications. So you need more and more to get the same effect. Once you get to a certain point of more and more and tolerance, you can get to withdrawal. Physiological withdrawals. Very severe withdrawals from benzodiazepines can be lethal. And so I'll sometimes see these patients that are on really high doses meant to affect their sleep, but it's no longer helping them sleep, and the process of addiction has already started. Even in small doses, if you pull away some benzodiazepines that people have been on for a good period of time, you will get rebound insomnia. So that then reinforces the pattern of using benzodiazepines. If I don't take it, I will get rebound insomnia without any other solution. And so then I'll go back to taking it, and then I'll need more and more. And so the cycle continues. Benzodiazepines can have significant cognitive effects as well. Benzodiazepines act on the GABA receptor that I was speaking to earlier and do many of the same things to the GABA receptor that alcohol does. And so I kind of think of this medication as, am I prescribing a drink for patients to go to bed? Now, that being said, there can be some pros to using benzodiazepines. If they're monitored closely for a short period of time, I think they could be used successfully. But they're probably not best used as a first-line agent, more second or third line. As I was saying, benzodiazepines act at the GABA receptor. And what they do is sort of a shotgun approach to the GABA receptor. They affect all subunits of the GABA receptor, all alpha subunits, 4 of them. And that changes the configuration of the receptor, keeping it open, increasing GABA activity. And so because of this shotgun approach, benzodiazepines are more likely to lead to the tolerance and withdrawal. We have medications now that take a more targeted approach to the GABA receptor. These are Z medications, Z drugs. And because they only affect one of those subunits of the GABA receptor, they still help the GABA receptor remain open so it can, so it's inhibitory, but it doesn't affect the subunits so much that lead to tolerance and withdrawal, to rebound insomnia. And some studies actually showing that use of these medications with an antidepressant, if there's a sleep issue, may even help remission rates for some disorders. The cons are that there's no real clinical guidelines for use of these medications in psychiatry. There's no real guidelines on treating the comorbidity, the common comorbidity of insomnia, and a lot of these issues. We kind of use our medications to do the best we can, but guidelines, practical guidelines are lacking. Other pharmacotherapy, melatonergic agents, melatonin. Melatonin over the counter can be tricky because the dose is not always reliable. It affects circadian rhythm. I'll talk a little bit about melatonin later. Serotonergic agents. Trazodone is a medication that is very commonly used in psychiatry to help with sleep. Trazodone itself is actually an antidepressant medication. In order to get a good antidepressant effect, you need pretty high doses twice a day, which is not really conducive to people functioning very well during the day. So we end up using smaller doses, sometimes larger doses, to help with sleep at night. It can affect sleep in multiple different pathways in the brain. H1 you see there is histamine. So there is some histamine blockade that can occur with trazodone. Excuse me, and talking more about antihistamines, diphenhydramine, hydroxyzine. Anytime you block antihistamines, you can lead to decreased wakefulness. Many psychiatric medications also block histamine. And so those are one ways in which medications can help people with insomnia, sleep disturbances, other mental health issues. Chronotherapy is something that I find pretty fascinating. It's essentially kind of hacking the circadian rhythm. Remember, I was talking about those zeitgebers, those time givers, those things, external influences that affect our circadian rhythm. When we lose our Zeitgebers, when we lose, say, a regular day-night cycle, if we're far in the northern hemisphere or southern hemisphere, that's a Zeitgeber that can get thrown off, and then our circadian rhythm can be thrown off. We see that a lot in seasonal affective disorder. Things like fresh air, exercise, activity can all affect our circadian rhythm. So in the northern winters, when we are going to the office in the dark and we're sitting in a room that may or may not have a window, and we're mostly inactive, and then we're driving home in the dark, we're losing a major indicator for our circadian rhythm in the sun. And so a couple of different things that we can use for chronotherapy. Bright light is meant to simulate the sun, and special bright light lamps. And so if we are finding a delayed sleep phase, for instance, we can actually have a patient or a client use bright light in the morning as an artificial Zeitgeber, as an artificial stimulus to promote wakefulness during the morning, helping them get up. The idea is the more you have that stimulus repeatedly, your circadian rhythm can actually change. The hormone cycles related to our circadian rhythm can change. Conversely, in advanced sleep phase, when people are falling asleep too early, and I mean pathologically 2, 3 p.m. in the afternoon and can't stay up later, we'll use evening bright light to help promote wakefulness later in the day. Melatonin is commonly used. Melatonin is I find very interesting. You'll see in gas stations, you'll see in drugstores, very high doses of melatonin, high doses of melatonin, 10, 20, even higher, which is not necessary. The reason that they're using such high doses of melatonin is because at the very high doses, yes, it can cause sedation. But that comes at a cost, because if you're flooding the brain with melatonin, you're really kind of throwing off the body's own natural melatonin cycle. And so you're not doing your circadian rhythm any favors. And so what I recommend for use of melatonin is taking the melatonin, essentially, there are different protocols, but essentially when we want people to be falling asleep or becoming tired going towards sleep, we use smaller doses, 3 to 5 milligrams initially, and then 0.5 milligrams for maintenance. That's all you need. Patients have a difficult time sticking with that, however, because they're not often educated that this is going to take a while. You may not experience the sedating effects of melatonin right away, but as it's working in the background, it is affecting your circadian rhythm, getting things more on track. Light therapy I find very fascinating. It's something that I've tried to incorporate into my practice. This is the use of special bright lights. So a specific light intensity of 10,000 lux. These are special lamps that you can get online. The duration of exposure that we want people when they're using bright light for either mood disorders or sleep is 20 to 30 minutes. If we're trying to promote wakefulness during the day, then we'll have them use the light ideally 40 minutes after sunrise. The type of light is you want it to be UV filtered, full spectrum light. And you want the field of illumination. You want to stimulate the sun as much as possible. You want the light to be sort of above the head, within a foot of the head, and shining down. So just kind of diagonal towards the side of your face. Now, chronotherapy, besides being helpful for sleep, is also helpful for depression, not just seasonal depression, but regular depression. This is a very fascinating study that was done, the CAN-SAD study, finding 96 patients in Canada with seasonal affective disorder. And this is a randomized controlled trial of light therapy versus fluoxetine, which is an antidepressant for treating seasonal affective disorder. Essentially, there were two arms of the study. One arm of the study where participants received the full high dose light, the clinically effective dose of light, and a placebo pill. The other arm of the study received the active antidepressant and the placebo light. So essentially a light that was not bright enough in order to have a clinical effect. The astonishing thing is that when treating seasonal affective disorder in this study, they found no difference in clinical response rates, 67% for both. And remission rates of 50% and 54% respectively for the two arms in the study. So right there you have a light, something that anybody could utilize without a prescription, being just as effective as a medication in this in seasonal affective disorder. In this study, both treatments were generally well tolerated, but there are higher instances of side effects with fluoxetine. And I'll just say this is absolutely anecdotal, but I've had a lot of my patients who are prescribing bright light therapy find it hard to stick with that habit. Their morning routines aren't always conducive to waking up, timing, certain 40 minutes later, using 20 to 30 minutes of light, getting the light, getting it to their house, being able to do that consistently. So that could be an obstacle to using the light as well. Light therapy can be helpful for not just seasonal affective depression, but also regular depression. There was a large study that took meta-analysis of randomized controlled trials for light therapy used in mood disorders. Science was not great in a lot of these studies, so they only used 20 of 173 studies. Only 13% of the studies met their criteria. And there are a few takeaways. Bright light or dawn simulators were effective for seasonal depression. And bright light was also effective on its own for non-seasonal depression. Bright light in and of itself can be helpful for just plain old depression. That being said, bright light was not effective as an add-on to an antidepressant for non-seasonal depression. So using an antidepressant as well as using a bright light, when you add on the bright light for non-seasonal depression, it doesn't add a positive effect. Different in seasonal depression. So thank you for your attention so far. At this point, I'll move on to Q&A.
Thank you so much, Dr. Louden. It's time for the Q&A portion. If you do have a question, please use the Q&A button, not the chat feature on the Zoom taskbar, and we will try to answer just as many questions as we can in the time that we have left. If we do not get to your question, please send me an email message afterwards and I'll follow up with you. Okay, let's see. The first, we had several questions around melatonin, and I think you covered it at the end, but how does it long-term, many of the questions are, how does long-term use of melatonin affect sleep cycles?
Well, that's a good question. I'm not aware of a lot of studies on long-term use of melatonin, but if it's used effectively in conjunction with other treatments that we know are effective, it doesn't have to be long-term. And so you can use a protocol of 2 to 3 weeks of melatonin, starting out with the higher dose and then moving off to the lower dose at the same time every evening in order to get a positive response in terms of treating insomnia. So the goal of the melatonin is to get the sleep cycle back on track where it needs to be. Once it's back on track, ideally the body's going to take over from there. And so what you want to do then is hand off the artificial melatonin usage back to the body so the body can take over. The problem with these high doses of melatonin is that's just confusing for the body. You're just kind of throwing melatonin at it, and then all of a sudden this artificial melatonin is gone and the body isn't really primed to take back over that circadian rhythm.
Okay, thank you. That's very helpful. Our next question is, when would you use CBT versus medications for insomnia?
So there's really no, there's no either or. You can use both in conjunction with the other. there are pros and cons to both. Cbti, like I went over, is very effective and also can help promote long-term improvement in sleep. Medications can be helpful in the short term and long term. They can be helpful for reestablishing that association between bed and sleep if they have a little bit of a help tipping point. That being said, then the association is made between a pill and getting to sleep. And so then the association that can happen is no pill, don't sleep. And so in a way, not necessarily addicted to the medication, but reliant, but that association is made. And I've seen patients that they don't have their pill, and that leads to hyperarousal and that they can't get to sleep. I would say, by and large, and I mean, we see this all across psychiatry and the mental health field, is a combination of both can be really effective, and one doesn't have to exclude the other.
Okay, thank you. There have been a few questions about different, like third shift at work, if you work different hours or prolonged hours. Given the risk factors as a clinician, would you work to try to eventually support the client changing shifts, or is there a way to work around that to promote healthy sleep?
Yeah, this is always very tricky, and there's no one size fits all for a patient. It reminds me of a patient that I had been seeing who unfortunately had developed bipolar disorder and was a night shift ICU nurse. When, her bipolar disorder was under control, however, working the night shift in a stressful environment was putting her at higher risk for relapse. Of course, you run into the situation where it's just like, okay, we'll change your shift. Well, it's likely not easy for anybody, and and in some jobs impossible, or one might lose their job, lose their livelihood. So, like with anything in treating patients, it becomes a cost benefit analysis, and joining with the patient and educating them on the risks and benefits. If I have a patient who's depressed, developing insomnia, and they're working at night, I have to talk to them, educate them on why that's not helpful, and offer my assistance. I would say, if I can help in any way, if I could, write a letter, then I'm saying this is, working the night shift is affecting your physical well-being, then I'm happy to do that if that helps push the needle either way. Some patients are reluctant to do that. Sometimes we'll end up using medications to help in these certain types of situations. If somebody has to work with a night shift, then we'll want to make sure that they're trying to get restful sleep during the day. And that can involve using medications. That can involve, trying to affect the different stimuli that are out there. For instance, I remember when I was in training, being on a night shift for 2 weeks at a time, 2 weeks on, 2 weeks off. What I would do during the nights, I'd want to try to sleep during the day. And so on my way home in the morning, I'd make sure I had my hat on for shade over my face. I had my sunglasses on so I wasn't getting bombarded with the morning light. I would try to make sure that my shades were drawn at home so they don't come home to a big bright place. And just trying to educate patients on how their environment, when they're not working, can be more conducive to sleep and more conducive to establishing a healthy circadian rhythm.
Thank you. The next question comes from someone who works with adolescents, and she states that they frequently talk about their anxiety spiking in the time after they turn off the lights and are laying in bed. Do you have any strategies specifically for managing the rush of emotions or worries that may been put off during the day and then they become a distraction at night?
Yeah, this is a problem, and it's not just for adolescents. It's for adults as well. Is using, most often the cell phone to distract from these anxious thoughts, these anxious feelings. And as soon as you shut the cell phone off, that distraction is gone. The anxious feelings can come back. And so, the other thing that the cell phone, as an aside, the other thing that the cell phone does in that situation is cell phones emit light. They emit bright light, and including the blue wavelength of light, which is the wavelength of light that our eye perceives and brain then perceives as daylight. And so they're actually activating themselves, could be contributing to that hyperarousal upon turning it off. It's just masked by being distracted by being on the cell phone. And so the big thing, A is psychoeducation. Why this is harmful, why this could be negatively affecting their sleep, is the use of distracting measures while they're in their bed. It also creates the association of being awake and being stimulated with bed, going over some of the things that we talked about during the webinar today. And then also empowering the patient the best that we can as providers to use relaxation techniques, find different ways that they can use to calm down. If they really love their cell phone, then maybe helping them find some different apps that are more geared towards, guided breathing or guided meditation. Or I think there's even different apps now that have like celebrities read you a bedtime story, just kind of like these different things out there that can help them relax. And so the key will be finding something that they enjoy, they find relaxing. That can be really hard in somebody with an anxiety disorder. But the idea is underlying it, you're treating the anxiety disorder, you're helping them, empowering them to relax at night. And they may also be working with a primary care doctor or a psychiatrist who can help perhaps with some medications as well to help get them some restful sleep.
Thank you. And that kind of goes along with, should we emphasize reducing screen time? A lot of questions around that. And if you were using CBT, what might be some indicators that would indicate that a medication consult is needed?
Well, I would say first and foremost, if there's a large contribution of, you highly suspect a mental health diagnosis that could respond to medications that are affecting sleep. If somebody's not sleeping because they're terribly anxious or terribly depressed and could potentially benefit from medication for those underlying conditions, then that's a no-brainer. That's when to refer. And as we know, therapy in conjunction with medications can improve the efficacy of those treatments together, and talking about anxiety and depression. If CBTI is, if the patient's really struggling with those associations, I've seen patients where they get into their bedroom and it's almost near panic time, because they've associated it with the anxiety, they've associated it with the distress. And so sometimes, like I said, medications can help change that association so that they're more drowsy getting into sleep and sort of push them more so into sleep. If CBTI isn't working, or if you just feel like a combination approach could be helpful, I don't think there's anything wrong with necessarily getting a medication consult. I do have concerns about the overprescription of benzodiazepines in that setting. And so that's something, that you might want to discuss with the client or the patient before the medication consult, or if at all possible, collaborating with the prescribing provider on the primary reason for referral, and whether you anticipate benzodiazepines would be a part of that. And if so, why? There may be a very good reason.
Thank you. There was a question, what are your thoughts on sleep monitoring apps such as Sleep Cycle?
Well, I think that goes back to how a sleep diary can be helpful. A lot of patients, I'm often surprised by how little knowledge they have of their sleep. Ask them how much they slept last night, and they'll flat out say, I don't know. I don't really track my sleep. I don't really monitor it. At some point I fall asleep, at some point I wake up, and that's that. And so any sort of monitoring, it doesn't have to be paper and pencil. It could be an app that monitors sleep, that monitors time of sleep, time of wake, quality of sleep. Ideal is also being able to take note of environmental factors that are contributing to sleep, whether they took their medications that night, whether they didn't take their medications that night. All these factors, so then becomes data that the provider and the patient can learn from in order to start change. But if you have a patient who really isn't really ever, they're struggling, they know they're struggling with sleep, but they've never really paid attention to their sleep or their sleep habits, you've got to start with data because they may not be the best reporters when it comes to that, not by their own fault.
Thank you. There is a question on wakefulness and ADHD.
Mm-hmm.
Is it true those with ADHD need less sleep? And do you have any suggestions for sleep hygiene, especially for kids with ADHD?
I'm not aware of any information correlating patients with ADHD needing less sleep. But it does bring up, the question is very interesting from the standpoint of, we have these tools, we have CBTI, we can talk about sleep hygiene, but if somebody has ADHD, it's going to be an additional difficulty for them to incorporate probably some of these techniques. A lot of my patients that have ADHD, their stimulant medication, which may help them during the day, has run out. So their mind is racing, they're very distracted, their brain is seeking out stimuli at night. And so it's very hard to calm the brain at that point when ADHD is sort of taken over. It doesn't mean that we can't use these techniques. It just means that we have to take into account the patient's ADHD and what may work best for them. Are they going to be able to sit in silence and focus on their breathing for 5 minutes at a time? Maybe not. Would it be helpful to have some sort of auditory cue for them to relax? Maybe that's something to be considered. Would you want to consider helping with medications to help push the habit of sleep, to push that sleep association into gear? We want to use more melatonin. We have a lot of different tools in our arsenal, but I mean, you bring up a good point. By and large, people with ADHD, it is going to be harder. If they're struggling with insomnia, it's going to be more difficult for them to incorporate some of these techniques that we're talking about. But it does take some persistence and perhaps some creative problem solving.
Thank you. With regard to increased risk of suicide and insomnia or nightmares, is this causal? What is the mechanism?
Is it causal? And what is the mechanism?
Thank you. Thank you.
That's a very good question that I don't know the answer to. I think if we knew how insomnia then has a direct correlation to suicide, that would bring us a lot of steps closer to understanding suicide, neurophysiology of suicide, neurophysiology of mental illness. We right now, as far as I understand, just have sort of a correlation there and not necessarily causality.
Thank you. This comes from a participant that has patients who complain about having to get out of bed for stimulus control when they can't sleep. Do you have any suggestions on how to motivate them to do this, especially in the winter when it's cold?
It brings me to a part of psychotherapy called motivational interviewing, right? And just kind of laying out, these are the techniques that we know do work. You don't have to use them, but in the long term, what are your values? Are you valuing being able to get some more solid sleep consistently, which this technique might help with? Or is it really just too big of a bridge to cross, and sort of walking them along the pathway of risk benefit? And so the other thing, it's just too cold to get out of bed. I perfectly, I can relate to that. And I think at that point I would sort of, encourage them to consider different environmental factors. Can they keep a really comfortable robe right by their bed that they can jump into? Can they control the temperature in their house? Do they have a favorite chair that's very comfortable, which they can, use to maybe read or do something that brings them towards sleep, that makes getting out of bed not such a uncomfortable thing.
Thank you. That's about all the time we have for questions. If I didn't get to your question, please feel free to send an email to webinars@rogersbh.org. Many thanks to Dr. Louden for taking the time away from his clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. Before we conclude, I'd like to ask Dr. Louden to share a few recommended resources on this topic with our participants.
Yes. Sleep guidelines and sleep recommendations, information about sleep are everywhere, from from studies that you can see online to message boards that may not have the best information. I would point you towards the American Academy of Sleep Medicine Sleep Foundation. The CDC actually has a lot of good information on sleep. And then this website I'm not as familiar with. I think that was something that Dr. McCullers had on there, is the Center for Clinical Interventions. Some resources, some clinical resources for people to look at their sleep and educate them on sleep.
Thank you. That about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. Within the next 30 minutes, you'll receive an email with a link to your personal dashboard on ce-go.com, where you will all be able to access PDFs of the PowerPoint slides, as well as a complete list of the references. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this follow-up email, please contact support@ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Have a great day.